to highlight why pediatric spaces in specific. So, pediatric cases, first of all, children have a compact anatomy and they have a very rich vasculature. Their myelination is inadequate. It gets completed by 12 years of age, which actually allows for a dense and fast onset of blockade. There is a variation in pharmacokinetics of the local anesthetic. They have an increased cardiac output and low tissue binding, especially in neonates where the volume of distribution is also high. So there's always a faster uptake of block, but then there's also a faster reset for the block. And there is a high risk of accumulation of local anesthetic on continuous infusion. There is low levels of alpha acid glycoprotein as well, which increases the free concentration available, free local anesthetic available in the plasma. And usually we give general anesthesia or mild sedation before we administer regional anesthesia to these cases. So here I would like to discuss about a case of a 3-year-old child weighing 15 kgs with parents concerned about a deformity in the right hand and right forearm since birth. His birth history was full-term LACS delivery with birth weight of 2.6 kgs, and the child immediately cried after birth. But the patient had history of cyanosis at birth and was diagnosed with a VST. Patient underwent a VST repair surgery, and after that, we saw the patient. The general parameters were all within normal limits. Milestones were achieved up to the date. On local examination, we found a right hand radial deviation, ulnar bowing, and hypoplastic thumb with good circulation and no DNVD. The spine was normal, no abnormality detected. Before the surgery, the patient was already undergoing a follow-up. The stretching manipulation splintage done for 4 months for passive deformity correction. A gest fixator was then applied to elongate the radius via differential distraction. And then after the distractors were removed, the patient was finally planned for a radial centralization with radio-ulnar synostosis of the hand. So I would just like to shortly discuss about radial club hand. That is just a group of complex congenital deformities affecting the radial side of the forearm. It can involve broad spectrum of deformities from thumb hypoplasia to a complete absence of radius, and it involves the underdevelopment of the associated connective tissue and neurovascular bundle. It can involve from absent distal radial epiphysis to a complete absence of radius, and it is commonly associated with Bacterial Vater syndrome, Holt-Oram, and thrombocytopenic absence of radius syndrome and Fanconi's anemia. Hence, we ordered a spine X-ray, USG KUB, complete blood count, and 2D echo to identify the associated conditions. In our case, the patient was already diagnosed with VSD and treated for the same. So, what was our planning? Pre-procedural counseling was done regarding the anesthesia management and post-op pain management, and informed consent was obtained. Pre-op fasting was maintained for 6 hours for solids and 2 hours for water or a carbohydrate-containing clear fluid. Pre-medication was given by intranasal midazolam 0.3 milligrams per kg, and standard monitors were applied, vitals noted, and an IV access was secured. Induction was done by injection fentanyl 2 microgram per kg and propofol 2 milligrams per kg. An airway was secured by Ambu Aura LMA size 2 cuffed. And maintenance was given by oxygen, nitrous, and sevoflurane, maintaining a MAC of 1. Now, the regional anesthesia plan was an ultrasounded guided infraclavicular block with catheter placement, which was done under all aseptic precautions. And after the placement of catheter, an initial bolus of 0.25% bupivacaine, 0.5 ml per kg was administered. So, just briefly discussing about infraclavicular approach. This approach allows nerve block of the cords. So the axillary, as you can see in the image, pectoralis major and minor, which is separated by an epimysium, and just beneath that we can see the axillary artery. Now the first thing we see is a hyperechoic lateral cord. The medial cord is often lies between the axillary artery and vein, and the posterior cord, which is often missed because of an acoustic artifact to the axillary artery, lies deep to the axillary artery. There is a great deal of anatomical variation present at this level. This block covers the upper aspect of the anterior, posterior, and lateral aspect of the arm and the entire limb below it. So the position given was the arm was abducted laterally with the elbow fixed to a 90-degree angle. We use a linear high frequency or a hockey stick probe in these cases. The probe is placed perpendicularly over the mid-clavicle, and the subclavian artery is identified. The probe is then moved laterally, where the subclavian artery just transitions into the axillary artery, and this point is inferior to the coracoid process. A 22-gauge needle is entered in in-plane approach with a steep angle from cranial to caudal direction. Our goal is to deposit the local anesthetic in a U-shaped pattern around the artery with a volume of roughly 0.2 to zero point 0.5 ml per kg. So as you can see, in this case, we had used, as I just described, we had just used a uh, catheter and tunneled it. Here you can see the needle entering the subclavian artery pulsating here. Now, a few things about this block. There's a great deal of anatomical variations, like I just said. The nerve structures here appear more hyperechoic compared to the supraclavicular area. The cervical pleura is the closest to the brachial plexus at the medial location in the infraclavicular fossa. Hence, we use a more lateral approach. In children, the coracoid process, which is used as a landmark, may also be underdeveloped. A single injection technique might be sufficient as the anatomy is very compact. Complications, although rare, or there might be a risk of pneumothorax, especially from a medial injection, an intravascular injection, or bleeding at infection injection site. Another thing to consider is why do we use a ultrasound guided approach in this case, and why not the peripheral nerve stimulation? We can use PNS, but there is, as you can see, it's a developmental disorder. The muscle attachments are altered, the nerve course is variable, the IP and MCP joints are fused, there is hypoplastic fibrosed muscles. So we actually might not even obtain the finger flexion, wrist flexion in response to a nerve stimulator. And the sensory supply of hand is by the median nerve, and the musculocutaneous nerve is often absent, and the radial nerve terminates at the elbow. So, an ultrasounded guided approach is more beneficial in terms of securing accuracy with the block. But Ponde et al. Also have described successful use of nerve stimulator in an infraclavicular coracoid approach by using the endpoint as pronation, supination, or twitches at the surgical area. Briefly talking about the brachial plexus, we have the roots of C5, C6, C7, C8, and T1, which merge to form the trunk, superior, middle, inferior. Following that, we have the anterior posterior divisions, which form the lateral, posterior, and the medial cord. The branches of importance or relevance as such are the musculocutaneous, axillary, median, radial, and ulnar nerve. The dermatomal distribution, osteotomal distribution, and myotome distribution is of importance, especially when we have to decide what level of brachial plexus we should be blocked. The approaches to the regional anesthesia technique here are interscalene approach, supraclavicular approach, subclavian perivascular approach, infraclavicular approach, costoclavicular approach, and an axillary approach. The axillary approach. This approach provides analgesia to the forearm and hand via the radial, median, and ulnar nerves. So, as you can see in this, the biceps brachii lies on the first thing we see is the belly of the biceps. Following that, we see the radial nerve, which lies deep to the uh, the median, the ulnar nerve, which lies deep and medial and superficial to the biceps. We can see the ulnar nerve, which lies medial and superficial, and medial nerve often located anteriorly to the axillary artery. The musculocutaneous nerve here separates from the sheath and lies between the belly of coracobrachialis and biceps brachii. The position again over here is supine with arm abducted to 90 degrees. Elbow may be flexed or extended. We similarly use a linear or hockey stick probe. The probe is placed high in the axillary fossa perpendicular to the axillary folds. The axillary artery is identified. The median, ulnar, and radial nerves are visualized, and a 22 gauge needle is used with an in-plane entry from lateral to medial direction, the upper arm. Our goal is to deposit the local anesthetic in the neurovascular sheath between the axillary artery and the conjoint tendon, which is formed by the biceps and coracobrachialis tendon. A volume of 0.3 to 0.5 ml per kg might suffice for blocking the nerves. As you can see over here, the musculocutaneous nerve must be blocked separately. It lies between the coracobrachialis and the biceps brachii. Although this block has a limited coverage, it has an advantage of being performed in a compressible location. It is particularly useful for syndactyly reconstruction surgeries where both the hands have to be repaired. And potential complications, well, we might have to give multiple separate nerve blocks. As you could see, we have to separately block the musculocutaneous nerves. This multiple injection sometimes can lead to neurovascular trauma and might not be necessary in the pediatric population, but this is a potential complication. With respect to our case, why we a continuous axillary nerve block, since we had to place a catheter for continuous infusion post-operatively, this area has a high mobility, so there is a risk of easy catheter dislodgement. Coming to the supraclavicular approach. Now, this is the brachial plexus block at the level of trunks. Important sonal landmark over here is the rib. As you can see over here, the subclavian artery is identified and the cluster of grapes can be seen right next to it with the pleura beneath and the first rib beneath. This particular block also provides a similar level of analgesia to the upper arm and lower rest of the forearm. With the head with the patient in supine position, the head is turned to the contralateral side. The shoulder may be extended with a shoulder roll to stabilize the head and provide more space to maneuver the needle and probe. We use a linear high frequency or a hockey stick probe. First, we identify the clavicle and place the probe upright behind it in a coronal oblique vein. The first thing we do is identify the subclavian artery and the subclavian artery. Lateral to this is a honeycomb-like hypoechoic cluster, which is the brachial plexus at the level of trunks and divisions. A 22 gauge needle is advanced lateral to medial and just superior lateral to the subclavian artery. The goal is to deposit local anesthetic around the bunch of grapes with a volume of 0.3 to 0.5 ml per kg. Another approach that can be used is an 8-ball corner pocket technique uh, we use the triangle which is guarded between the first rib, the brachial plexus, and the clavicle, and deposit the injection in this particular corner pocket. Now, this block again has a very high risk of pneumothorax as the cupola of the lung lies just medial to the rib and especially in the shorter children. So it is very critical to ensure needle tip shaft visibility. Potential complications can include an intravascular injection, pneumothorax, Horner's syndrome, bleeding and infection at the site, and phrenic nerve blockade. Because an effective blockade actually might have include a phrenic nerve blockade of up to 67%. With respect to our case, a continuous supraclavicular block is generally not recommended to be an optimal choice for placement of catheters because of the great mobility of the neck and the closer proximity of the pleura and the vascular structures. The alternate approach is the subclavian perivascular approach, which is, as you can see in this diagram, the brachial plexus and the subclavian artery just next to each other. This is the point at which brachial plexus is the most compact, and with single injection and the lowest volume, the block can be given. It is again sim the patient is positioned in a similar way. Same linear or hockey stick probe can be used. The needle is targeted towards the corner bordered by so yeah. So you can see the upper, middle, and the lower trunk can be seen, and the drug is deposited between the upper, middle, lower trunk and the subclavian artery. Again, this block also carries the similar risk of Horner syndrome, phrenic nerve blockade. The ICBN is not involved, or might not be blocked. The ulnar nerve may be missed in this case, and a risk of pneumothorax still exists in this particular case. With respect to our current case, this block may be ideal, but for catheter placement and for post-op pain management, the proximity of the subclavian artery is not ideal. The interscalene approach. This provides the analgesia of the shoulder and the proximal humerus. The trunks and roots lie posteriorly to the sternocleidomastoid muscle, situated between the anterior and middle scalene muscle. The C5, C6, C7 nerve ventral rami can be seen. The posterior trunk is usually missed in this particular block. As you can see, the subclavian artery and the vein. The interscalene approach, again, So here we have the same, we have the patient in the supine position with head turned to the contralateral side. The shoulder roll might be placed beneath the patient for better visualization. Similarly, we use a linear or hockey stick probe. The ultrasound is positioned in a transverse oblique plane at the level of cricoid cartilage on the lateral border of sternocleidomastoid muscle. The scalene anterior and medius muscles can be seen deeper to the sternocleidomastoid. Actually, in the pediatric population, we might also see the great vessels uh, just lying lateral to it. The hypoechoic muscle bundle of C5, C6, C7 can be seen in the interscalene groove. The traceback approach can also be used where a US probe in a coronal oblique plane at the midpoint and upper border of clavicle is placed. The subclavian arteries visualized, the brachial plexus at the level of supraclavicular fossa are seen, and the probe is taken back up to the level of C6 and until we see the interscalene groove. The goal is to deposit the local anesthetic within the correct tissue plane in the interscalene groove. And a circumferential spread might not be required. A volume of 0.3 to 0.5 ml per kg can be used. Franco et al. Suggested that the traffic light sign, which is classical of the interscalene block, may in fact be just two nerves, a C5 and a split C6. Therefore, the injection between the gap of C6 and C7 would indeed be an intraneural injection at C6, which could potentially spread to the neuroaxial space as well. Important to consider that can lead to Horner's syndrome, a hoarseness due to the recurrent laryngeal nerve blockade, and a phrenic nerve blockade leading to ipsilateral hemidiaphragm. Can also lead to subarachnoid epidural and vertebral artery injections. This is especially true in cases of pediatric population where there is a very close proximity to of all these structures, and a high volume can definitely lead to such complications. Pertaining to our case, this approach will not be useful due to ulnar nerve sparing and various complications that are associated with the block. It is more suitably applied on a shoulder or a proximal humerus surgery. Talking about the costoclavicular approach, this is a variation of the lateral sagittal infraclavicular brachial plexus block. The space, costoclavicular space, is bordered by the clavicle, subclavius, and the pectoralis major muscle anteriorly and the anterior chest wall posteriorly. The axillary artery, vein, and the brachial plexus pass through this cavity to the lateral infraclavicular fossa. The brachial plexus cords are just clustered just laterally to the axillary artery, similar to the supraclavicular view, but it is performed below the clavicle. Local anesthetic is injected medially into the costoclavicular space with the ultrasound probe held parallel to the clavicle. The advantage is it is a single injection technique with faster onset and there's an effective drug distribution. This is especially beneficial for catheter placement. Cords are also more superficial and grouped together, allowing for an easier access. The position is similar to the infraclavicular block that is given. The probe is again placed parallel to the clavicle. We start from the clavicle and direct the probe laterally and caudally with the side separate drilled, and a single injection with a 22 gauge needle with an in-plane entry is sufficient. The drug is deposited into the costoclavicular space where the tip at the tip where the center of three cords in the gap between the posterior and medial lateral cords. As you can see here, the gap between. This is how the drug is deposited, and we need to especially watch out for the thoracoacromial artery in this case, which can be present at the needle entry point. A Doppler might help us to visualize this. In pediatric patients, especially children under 5 years of age, the coracoid process again is not very well developed. So the needle orientation, so in this case, the medial lateral approach is considered as an alternative method. In this approach, the use of ESG minimizes the risk, although the close agency of the neurovascular structures is a disadvantage. This block is favorable for our case, but the proximity of the catheter in situ with the pleura is of concern. Lastly, why is infraclavicular approach the best approach? The infraclavicular approach to the brachial plexus provides suitable anesthesia and it is well stabilized and in a secure position for a continuous infusion. The dermatomes covered by the block are sufficient, especially for post-op analgesia. The infraclavicular brachial plexus block offers a small distribution of coverage, but its lateral placement helps to decrease the possible inadvertent puncture of the lung apices and avoids phrenic nerve involvement compared to a supraclavicular block. It is relatively challenging. Depth can be navigated with ultrasound guidance, but this problem is often not faced in the pediatric population. Thank you.
What? Good evening. This is Dr. Neeta here.
Yeah,
Shefali, am I?
Yes, ma'am. Good evening.
Yeah. With regards to volume, concentration
Mm,
at different levels in pediatric population
yes, ma'am.
across the
So,
brachial plexus in the interscalene, in the perivascular subclavian, axillary.
yes. So, in pediatric population, usually for the brachial plexus at interscalene level, a zero point 0.2 to zero point 0.3 ml per kg volume is sufficient. In fact, it's more than sufficient to give adequate analgesia for the required law. For the supra and infraclavicular approaches, we can go up till 0.5 ml per kg as well, but it is often not required. We can use the ultrasound to real time see the spread of the volume as well, which can help us guide. So we do not usually exceed 0.35 ml per kg. That is often sufficient. But also the age of the patient matters over here. The build of the patient matters. If we are talking about above more than 10 years old, we would like to give more volume as there is more as it can that can be accommodated. And we would, for sensory blockade, we would like to use zero point 0.1 to 0.2% ropivacaine or 0.25% bupivacaine. Ropivacaine is generally more preferred as it is less cardiotoxic and gives a higher sensory blockade rate.
Do you do these blocks regularly?
Yes, we do.
So is it for post-op analgesia or you're targeting surgical anesthesia?
So since the patient is under general anesthesia, we do target it as a post-op analgesia, especially if we are using continuous catheters.
Okay. And is it given at the start of surgery or is it given post-operatively?
It's given at the start of the surgeries usually,
Okay.
and we
So
might
since you're
use.
talking about upper limb, most often in pediatric, the procedures that you have encountered or in your setup, can you just enumerate the common ones that are done for which you're using catheters and for which you're using single shot blocks?
So the most common that we see is supracondylar humerus fracture. Uh, that is the most common that we see in trauma. Then we have the radial club hand. We have syndactyly procedures for which we use. For radial club hand, we use the continuous catheter infusion post-op as well. It's a big surgery. And for syndactyly, we might use a single shot. And this is the most common we see is actually supracorneal humerus, or it can be deformity correction as such, cubitus valgus, and an absent humerus also. So that is the spectrum.
In pediatrics with such congenital anomalies, have you seen variations in the nerve supply?
Definitely, there are no variations in the nerve supply.
So how do you
It's
go about assessment and assessing pain in this pediatric age group? One thing, one aspect. And what about the variations? So you actually scan and see first?
Yes, we do a pre-scan analysis to see if there is any variation in the neurovascular bundle. Especially, there are different, as you can see in this case also, the radial nerve was terminating just at the level of elbow, and the musculocutaneous nerve is often absent only. That's not even seen. And that which actually implies that we end up targeting a different nerve. A different nerve supplies the hand, not the conventional nerve that is present. So
So,
we have,
so how is that taken care of? Like which catheters would you prefer putting and with regards to fixation techniques?
we can use the available commercial continuous nerve block catheters that are present. We can also use a Tooheys short beveled 20 gauge needle to help us thread the catheters in situ. Usually 25 to 22 gauge can be used.
Tooheys would be catheter with a needle, right?
Yes.
So have you encountered any possible uh, complications with such technique?
Not really, since we are using an ultrasound to provide us with a real-time
Yeah,
visualization.
but have you noticed any leakage and seepage around the point of entry?
So we do tunneling so that there is no dislodgement, and we have not really seen any leakage around the catheter as such.
And how much of the catheter is advocated to be placed
Around 2 to 3
Yola,
centimeters within, since the
in all
nerve.
pediatric age groups?
No, so the nerves are present at different levels for different age groups. If we are talking about
Yeah.
less than 3, 4 years, we see the neurovascular bundle right just between 1 to 2 centimeters. So we not go as deep in the beginning.
Correct. So if it is too deep, it can actually get kinked or blocked and not be as effective. So fixation is definitely difficult in such
Yes,
cases. Specifically, the surface area and the area is very small for
very
even
small. Yes,
achieving tunneling.
yes,
With
yes.
two, is the issue is of seepage and leakage at the point of entry for sure.
Point of entry. Yes.
If it is for KY, or are you still giving blocks? Is it advocated? Do you know of any evidence stating that in pediatrics it would be beneficial?
If you're talking about, so if there is also reduction involved along with KY fixation, definitely a single shot block helps. It reduces the post-op, opioids that are given or analgesics that are given, and the patient is very comfortable because in our age group, babies, small babies cannot even express anything. They just cry incessantly. So it is one way of securing the analgesia post-operatively.
Okay. Since you came to it, your assessment scores at different age groups. Although Shefali has presented, others also have um, the right and the responsibility of answering and participating in the discussion. So, other fellows, please do participate. What are the modalities we have in assessing the pain scores in pediatrics, whether it is a baby, a toddler,
We have
and
the
a child who, yeah, who's
we
a
have
little
the
more elder, like maybe an 8-year-old?
For an elderly child, we can use a VASCOR also. They can comment on their pain level, and we have the CHOP score as well, which we see the cry, the facial expression, and the verbal statements if they are able to vocalize of the patient.
If the block has failed, what is the plan B?
In case the block has failed, the plan B would to give obviously it would be to give IV analgesia as well along with it. And usually we cannot think of giving a block again because we do these procedures under anesthesia. Child will not cooperate for an awake regional blockade, obviously. So we can use suppositories, we can use diclofenac or paracetamol suppositories, which can help us manage the pain post-operatively. We can use ibgesic syrups as well. And at times for deeper pain, fentanyl patch can also be used with close monitoring.
In pediatric patients, you're using
Yes,
fentanyl patches?
it is used. It's not unheard of.
No, no. In your setup, are
Not
you all
not
using
no
fentanyl patches for
no no
pediatrics?
no not really.
Okay.
Our first
Have you heard of fentanyl lollipops?
yes.
Any other analgesic modality you will use? Any other medication or a combination of medications for pain relief?
Um,
Any other fellows wish to answer
can
about
use
multimodal analgesia?
Can we use low dose ketamine?
yeah.
Yes. What do you think the duration of analgesia? But of course, it will reduce the requirement of other medications. Anyone using dexmedetomidine or a combination of ketamine, dexmed? Yes, anyone? Okay. Mitali has asked what length of the catheter is advanced beyond tip. Does it vary with the weight of the baby? And anatomically, if it is threaded, in fact, for brachial plexus, if it's beyond a centimeter or two, uh, it can actually cause kinking because, like in adults, we can have it up to 1.5 to 2 centimeters. But if it's longer, it can actually tilt over itself. It can get dislodged. It may not be in its ideal place. So the complications are much more. Dislodgements, displacements are much more. So a catheter usually, even if it stays for a good 36 hours, serves the purpose. That you have to be a little cautious about. It shouldn't be more than 1.5 to 2 centimeters beyond, for sure. Yeah,
Thank you,
anyone
ma'am.
else with regards to multimodal? Shefali,
Yes, ma'am.
you said you're using catheters for major surgeries of the hand,
Yes.
plastic reconstructive procedures.
Yes, ma'am.
So tell me, the next day if the baby is crying, how will you confirm the catheter placement, whether it is in place or it's displaced?
Uh, so, first of all, we use an infusion pump or an elastomeric pump to deliver our drug. So, obviously, if there is babies crying, the first thing is to check whether there is any kink in the catheter, as you mentioned, ma'am. We will give a small
How will
dose
you
of,
identify the kink?
we can give a small analgesic injection via the catheter and
Okay.
see whether there is any blockade or not. Usually, even an
Okay.
infusion
Say if
pump
there
will
is,
beep.
say there is a kink, then what is your next plan?
Uh, so if there is a kink present in this particular case, we can use the help of ultrasound as well to see the catheter in situ and identify the kink or not. Also, if there is a kink, we can we can we cannot we can change the first of all we can change the occlusive dressing that we have applied. Maybe there's a kink right at that level, uh, and that can be sorted with this. And if there is a, I'm not sure about how exactly to go about the other one, ma'am.
Anyone else?
Ma'am,
Anyone else?
I have a query. If we are
Yeah.
checking the catheter with analgesic dose, like if we are giving local anesthetic something, and if
Yes.
it is dislodged,
Yes.
so
Yes.
is there not any chance of having last or something? Like we don't know the position, and we are using analgesic
So,
dose for
So
checking the
ideally,
position.
whenever there is a catheter, ideally whenever there is a catheter, as you in the brachial plexus, we know that the caudal area is from there. It can be even, it can have a neuraxial spread. It can have a spread to the vascular spread where it can be dislodged. So ideally, negative to aspiration definitely has to be done one thing. Everything has to be given in small aliquots. So whatever targeted dose, if that sorry, I lost connection. Am I audible?
yes, ma'am.
Yes, ma'am.
Yeah, so unless you give a small dose, and if it's for that child, that dose is say 3 ml of bolus. So instead of 3 ml total, ideally in a small gauge syringe, at least um, maybe you can target one-fourth to half that amount to see whether uh, the patency is intact. And confirming, of course, the tip with negative aspiration. Whatever should be given is small, especially in areas, it's a small area. Type of drug should be given, and that definitely can happen with higher these days. Yeah, you can my network is so
Madam, we are
far.
not able to hear you.
Neeta ma'am, we are losing your network, ma'am, in between.
Yeah, my network is bad a little bit. I don't know why it's going in and out. Is there any other way to assess the like you give the local anesthetic and then wait for the baby to have pain relief? Any other method?
And I will just. Will you go over here? Will you go over here? Where will you put the catheter? So ideally, what has been described is you have to go somewhere over here. So what you will do is when your needle comes to this point, you will start hydrodissecting. So at this point, once you will start hydrodissecting, what happens is these cords get separated. Then you will pass the needle further ahead, and you will try to go in the center of this clusters between the lateral,
Yes, sir.
posterior, and medial cord, and you will try that your tip is somewhere over here. So the advantage of doing the costoclavicular block is your catheter tip is somewhere over here. Whereas if you see the lateral infraclavicular block, the tip is somewhere near the posterior cord, but the lateral and the medial cords are further away. So post-operatively, are you using continuous infusions or you are giving intermittent boluses? What are you using, Shepali?
Continuous infusions.
Yeah, so continuous infusion, what happens is the drug spread may not be even around all the cords. When you are doing an axillary or when you're putting a catheter in axillary or a lateral infraclavicular approach. But here, if you are putting the tip of the catheter is somewhere over here. So even with continuous infusions, the drug will spread will be all around. But many times, especially in adult patients, what happens is if your catheter is somewhere over here in your lateral infraclavicular approach with continuous infusions, the drug may not spread to the medial and the lateral cords because the arrangement is somewhere this way. Like this is the medial cord, this is the posterior cord, and somewhere over here is the lateral cord. And if your catheter tip is somewhere over here, the drug spread with a continuous bolus may not be to all the cords, and that's why you may have sparing of certain nerves, and this is called as a secondary failure of a block. So there are a number of studies that are coming up nowadays where they show that continuous, instead of giving continuous infusions, boluses are far better. So intermittent boluses are better. This is true in all blocks, even for facial plane blocks and for this particular approach. So the advantage of doing the costoclavicular approach is secondary failure of the block is far lesser than your lateral infraclavicular block. But as you rightly said, costoclavicular approach is more dangerous in pediatrics. I mean, it's very close to the pleura, etc. That's why we prefer the lateral infraclavicular approach. But you have to remember that one of the causes of lateral infraclavicular approach, the failure of the lateral infraclavicular approach is this point because your catheter is not close to the to all the cords. So that may be one of the reasons for secondary failure of the block. Uh, Over here, besides the thoracoacromial artery, Shefali, what other vascular structure can you see? if you see the thoracoacromial artery, actually your probe position is too distal. I mean, you should not be
Yes, yes,
doing the block.
yes, sir.
Any other vein comes over here?
Cephalic vein, sir.
Okay.
Yeah. So if you are seeing the cephalic vein, if your probe is too distal, you may see the cephalic vein coming this way. So
Yes.
if you see the cephalic vein or if you see thoracoacromial artery originating from the axillary artery, this is rightly said. Many people call this as a subclavian artery, but anything below the rib, this is not the
Yes.
subclavian artery. This is the first part of the axillary artery. So if you see thoracoacromial artery originating, that means your probe is too distal and you have to go more proximally. Even when you see cephalic vein draining into the axillary vein, it is your probe is too distal and you have to go more proximal. So that is not an ideal site for doing your costoclavicular block. And over here, can you label these muscular structures? What muscular structure is this? What muscular structure is this? And what muscular structure is this?
So we can see the pectoralis major and the subclavius muscle, like
Yeah, so
PM and subclavius.
this is the pectoralis major muscle,
Yes. And beneath it is subclavius.
and below that is the subclavius muscle. This is the
Subclavius muscle.
subclavius muscle. Which muscle is this? This muscle, the third muscle.
Serratus anterior.
Anterior sleeve of serratus anterior.
Yeah, so it is called as commonly it is called as serratus magnus. The anterior sleeve is
Okay.
called as the serratus magnus
Hmm.
muscle. So you should be able to identify the muscular structures as well. Any other person has any points besides this?
Sir, I want to ask one question that in a costoclavicular, the posterior cord and the medial cord lies in one sheath and the lateral cord in the other sheath. So if we put the tip in between the cluster, so does it helps to both the cords like posterior, medial, and lateral, all the three cords?
It does spread, especially in pediatric. You rightly said that this is divided into an anterior and a posterior division. So this is the anterior division and this is the posterior division. So this anterior division will have the lateral cord. The posterior division
Yes.
will have the posterior and the medial cord. So ideally, you should be in between somewhere over here so that your drug spread is on both sides. It is somewhat similar to your those adductor canal blocks, etc. So in adductor canal
Okay.
blocks, you have to block like two nerves, now to vastus medialis and your
And
main saphenous
saphenous.
nerve. So ideally,
Yes.
what people do is they try to put the catheter in such a way that the catheter has two holes. So the one hole will be lying over here and one hole will be lying over there. So drug spread should be on both the sides. But in pediatrics,
Okay.
like these divisions are not so like it is not so well defined as in adult patients. So you can get away even if it is just in the center.
Okay. Thank you, sir.
How about forearm blocks in pediatric patients? Anybody practicing forearm blocks? In adults or pediatrics, anybody? No one is practicing forearm blocks? Has anybody heard of an hematoma block? Are the participants there or they have left? Shefali?
Yes, ma'am.
Yeah, have you heard of this?
Yes, I'm heard of a hematoma block.
What is the logic or the concept? Any idea?
Uh, Ma'am, basically, we want to spread so in case this is usually done in trauma cases where we spread the local
Mm,
anesthetic within the hematoma between the fractured bone fragments.
mm-hmm.
So it is, as you said, it is considered in that distal forearm. Mhm.
What is done in that?
Ma'am, we use so we take the needle and we introduce it into the hematoma until we encounter the bone. And after, like we aspirate like around, after aspirating blood, we inject around 5 ml of the local anesthetic into that cavity. So it blocks the periosteum and nerves around that area, if I'm not wrong.
It usually is, as it's rightly said, but you may not be able to aspirate blood every time.
Yes, ma'am.
It can be done with fluoroscopy, where soft tissue edema and trauma is noted. Uh, Again, the effectiveness, the efficacy of the block is questionable, but used in trauma settings, especially where uh, you do not have advanced gadgets. Yeah. With regards to forearm blocks, has anyone tried them? So towards post-operative period, if it's something of the hand,
Yes, ma'am, I
say it is
have
of
done those,
yes,
but
yes,
like not in very proximal in the like just below the elbow or around the elbow. I have done those, but not in
yes.
pediatrics for adult cases.
Okay. So
Uh,
what needle, what gauge needle, and what strength of the local anesthetic would we target?
we have used zero point 0.5 anavin and means nothing different in adults with the Stimuplex 50 needle.
Okay.
But then
Okay.
precaution was there always that chances of nerve injury increases significantly. So you have to be very much sure that your needle is not poking nerve.
Yes. So even in pediatrics, in case of numbing that hand and making it immobile, if you'll do a good follow-up of pediatric patients, they get very frustrated with paralyzed hands and immobilized. If specifically it's not a major case and it's okay with the child moving the elbow and the shoulder to a little extent. So you may go ahead and use 26 gauge hypodermic needles, but word of caution, caution, caution is that the trajectory or the needle entry should be tangential or adjacent to the nerve that is seen, never towards or poking or pointing. The purpose of giving two with, a thicker needle definitely could be painful for the child, that puncture point, versus a hypodermic. So if you're using a hypodermic, which is documented in books, you need to go tangential, you need to go in the vicinity, and deposit maybe 1 or 2 ml will be more than enough. And I would suggest not using anything more than 0.25 for a peripheral block. Yeah. So 0.2 ropivacaine is good. Any other comments are welcome. Ideally, three or four of the fellows should chalk out the entire course of the four major nerves supplying the hand, right from the brachial plexus till the tip of the fingers. If anybody can do that, it will be great. Those are the questions from my side. Good presentation, Shefali.
Ma'am, can you repeat what exactly do you want us to do?
The course of the nerves, the radial nerve
Oh,
from the origin to the tip
okay.
of the finger, of the
Okay.
radial, axillary, uh, not axillary. You could say radial, ulnar, median, musculocutaneous.
Ma'am, I
Advantage being
think,
you should know where we can block it.
ma'am, we can ask the kids to share it on the WhatsApp group after drawing it so that all
Yes,
of them can practice
the
and share.
course is very important.
Yes.
So if you could draw it, it's there in many places. You can kind of get a hold of it, and otherwise it will be the same. I'll give this, that. But suppose it's something typically of the wrist. Where else could you block? Which muscles need to go? Which muscles need to go? Dermatomal, osteotomal. I missed a few slides of Shefali. Did you mention the osteotomal supply of the hand,
Yes, ma'am.
Shefali?
I had a diagram that I had put in place.
We usually only speak about the dermatomal supply. Yeah.
Yes, ma'am.
So it's very important because most often these kids, if you notice, there's never plating. It's always a K wire that is put in. Yeah.
Yes, ma'am.
Of the hand. Oh, okay. Okay, so maybe you can put it up as diagrams and finish the entire upper limb systematically. Anyone else wishes to ask questions, please do.
Shefali, have you heard of any can you go back to your axillary the slide of the axillary block? Yeah. So you have labeled this as ulnar, median, radial. Now, how do you know whether it's an ulnar nerve, median nerve, radial nerve? What are the methods to find out?
So we can trace the nerves distally and find out which one is which. Like we can see the ulnar nerve till the ulnar groove, which is superficial only. The
Yeah.
median nerve will usually follow the axillary artery, and the radial nerve will go further posterior into the spiral groove.
Yeah. So this technique is called as,
Uh, trace
yes, it's called as trace back technique.
back technique is.
Yeah. So sometimes it is not very clear which nerve is
Which
the
one?
ulnar nerve, median nerve, and radial nerve. So you have to resort to this trace back technique. Any other method?
Um,
You can use PNS,
okay.
right?
Yes, sir. We can
Just
use
use
PNS in this.
PNS
Yes.
and stimulate the nerve, and you will be able to make out.
Yeah.
This conjoint tendon, as you rightly said, this is the most important, just to reinforce this fact that this conjoint tendon is the first structure that you have to see. The structure about that is the third part of the axillary artery, and around that you have the nerves line. And this distribution of the nerves can be quite variable. So I think what you have shown as the ulnar nerve should be the median nerve. Is it correct? Can anyone, as far as I remember, this should be the so 1 second. So this should be the median nerve.
Okay.
Somewhere over here is your musculocutaneous nerve, right?
Yes.
Here you have the musculocutaneous nerve. So this is the typical location. Ulnar nerve can lie over here, but this should be the median nerve. This nerve over here is the median nerve. Generally, 2 o'clock position is your ulnar nerve, and radial nerve generally it lies at 5 o'clock to 7 o'clock position. So typically 11 o'clock to 1 o'clock or 10 o'clock to 12 o'clock position is for the median nerve. So this labeling is actually wrong, and this musculocutaneous nerve lies in this groove in the coracobrachialis muscle. Usually, you can see this groove. It is not so difficult to see. If you trace the musculocutaneous nerve back, then you should be able to see the nerves. So this labeling is actually wrong over here.
Yes, I should correct.
Yeah. Any other questions?
Shefali, the elastomeric pump which you're using, how do you know whether the infusion,
Sorry, ma'am.
the elastomeric pump
Yes, ma'am.
which you use, how do you know whether the infusion is ongoing?
We do see
And
a
if there is a
decline in
kink
the, yeah, that is very
in the,
difficult to assess from an elastomeric pump. Usually that is the problem. Infusion pump will show an occlusion alarm, but an elastomeric pump will not.
exactly. So I that is the only thing which I feel you cannot identify any kink. You don't know whether the solution is going. As long as the patient doesn't cry, it's fine.
We can
So
also see the
it
balloon
is,
deflating slowly. The volume
but see, in a
reducing inside.
pediatric patient,
Yes,
you won't be feeling too much, right? The volume
yes,
is also much less. To
yes.
actually appreciate 1 or 2 ml going per hour is not a very
Very difficult to
clear-cut
assess.
indicator. Yeah,
Yes,
you could be asked a single lumen at the tip versus perforated tip, the advantages, needle through catheter, catheter through needle. Yeah.
yes.
So which is a preferred technique for catheters? Catheter over needle or catheter through needle?
Catheter through needle, ma'am.
Why do you say so?
There is, first of all, there is less chance for the trauma to the catheter itself through the needle. I think the opposite technique will lead to that.
I didn't get you. What you said? Trauma to the catheter
Yes, ma'am. There can be the catheter can get damaged while threading.
while threading. Through the needle you're talking about, or
No, ma'am, the other one.
over the?
Yes, ma'am.
So those are usually that you place the needle, the catheter is over the needle. You place it and take the needle out.
Yes, ma'am.
The only advantage being the leak is much lesser. And especially you mentioned two H's. The leak around the
Leak
catheter
around the
in
catheter
a
is ma'am.
pediatric, it could be quite a bit. Yeah.
Yes, ma'am.
Last question, any adjuvants that first is what is approved in this pediatric age group? Any adjuvants that you would use rather than putting in catheters along with multimodal analgesia
Ma'am,
and
adjuvants
dosage?
with the regional anesthesia that were given, the local.
Adjuvants,
Yes,
yeah.
yes, yes. We can use clonidine, 1 microgram per kg.
Okay. Have you seen significant improvement in analgesia?
Yes, ma'am. It prolongs the duration of block significantly and increases the density of the block as well.
Do we want a denser block other than for
For
major
a single
surgeries?
shot, we would prefer a dense block for as in the
But
major
you said you're
surgery.
using it for analgesia, right? You're not using it for surgical anesthesia.
Yes, yes, ma'am. No, ma'am. Usually we
So,
would not prefer an adjuvant like that because also we will not be able to assess.
yes,
And there's higher risk of
and it is,
toxicity as well with the
yes, and as I said, it's not a very comfortable feeling for the child
for the
of that
child
age
as well.
group to have
Yes, ma'am.
a paralyzed limb. Yeah, it's quite
Yes, ma'am.
uh, quite a bit of a discomfort. So I'd appreciate if you all are really keen, if you all can produce diagrams of the nerves from the origin to the distal tip of the fingers including the digital nerves branches of what? Yeah.
Yes, ma'am.
Yeah. Who else is there? Sachin, Dr. Sachin, Dr. Prachi, any questions you'll wish to ask?
So my one question is, uh, if you have a child, 3-year-old child with fracture forearm, radius ulna, what are pre-op, um, op as an optimization or prerequisites that you would keep in mind as opposed to an adult and a pediatric patient? What are precautions would you like to take or difference uh, before inducing an adult versus a child?
So are you talking about the pre-anesthesia workup only,
Ye-
or
Workup, and before taking the child inside,
okay?
what anything special or different than you would do for a pediatric patient as opposed to an adult patient?
We would like to first of all rule out any congenital anomalies. The pediatric group often presents with that. Even if it's despite being a case of trauma, the patient can have congenital abnormalities. Patient can have cardiovascular congenital anomalies as well. So we would like to rule that out. Then adequate fasting also is very important. And URTIs are commonly seen in the pediatric age group. That also needs to be known before taking up the case.
So, per se, to the injured limb, the documentation of any nerve damage would be difficult
Yes,
in a pediatric patient, right? To
yes,
assess.
yes,
So, uh, having an EMG or something pre-op documentation in terms of any deformity due to the injury before giving any nerve block is, I think, is an important part, right?
yes.
Hello.
Yes, Dr. Sachin.
Yeah. So I just wanted, maybe Ankit can put a light on this. Is regarding the consent in pediatric, and how do you go ahead with explaining that nerve block is going to be given to the child? How is it different from an adult? Because adults generally would tend to accept the block procedure, but how is it different in case of a pediatric case where you have to explain it to the patient, parents rather, and so if you are giving a particular block and the it extends the motor blockade extends, how do you tackle that? What is different in the consent, and how do you tackle it in the post-op period? Maybe my question is not that relevant to the topic of discussion today, but just something that came to my mind. Sorry, I was in and out doing a case, that's why.
Even if conventional pediatric cases, they could also ask whether, getting an IV access for this child, types
Hmm.
of induction techniques that can be done.
Hmm.
Specifically, the children may not have an IV access. So you should be prepared with how you're going to, get the child inside the OT, secure the IV access. What are the other analgesic options that can be given? Yeah. So any other queries that the fellows have? A little bit of participation would be good, because if everybody stays numb, it's more like we're taking our own viva and answering our own questions. Yeah.
Sorry, Sachin. Sorry, Dr. Neeta. Sachin. What question did you ask?
So my question was that
With it,
how is the consent procedure different when you explain it to the parents? And
Okay.
is it of a concern that the say the motor blockade extends? Do we kind of prime them for that scenario where the limb is kind of having a kind of motor blockade in the post-op period? Does that cause them anxiety?
Definitely,
Do they think that?
definitely.
Yeah,
We always prime them because see what happens now. There is a lot of variability in the duration of action. Is there?
yeah,
Sometimes it do happen that we say that the action will remain for 12 hours and then it remains for more than that, or
yeah,
we say that for 6 hours there will be a motor blockade and after that, like you will have a sensation, but pain will not be there. So
yeah,
definitely we tell them that there might usually this happens very regularly when we give caudal or epidural
right.
because they are not able to lift the leg. So then during that time, like they're very everyone becomes very anxious, right from child to the parent. So we for each and every patient relative, we tell them that the duration of action might be variable. So that is one thing.
Right. Okay.
And one thing, Anita madam. So what happened? Usually we put a catheter.
yes, yes,
So
yes,
the practical thing is about like, for example, we are putting a catheter for a 6 month age or a 1 year old child. So the catheter which we get contiplex are much more bigger in size. So
yes,
uh, so for this, what we do is that we use either 20 gauge catheter, so which is a 2E needle. So in Contiplex, we don't have a smaller size of the catheter size. So what we do either 19 gauge catheter or we use a 20 gauge catheter and then we insert. So that is what the practical thing was. So your doubt about the perilic catheter around the insertion side. So if you use a smaller gauge catheters, definitely there is a reduction in the leakage of the around the catheter. So that is avoided with the using a smaller gauge catheter size. That is what we do. And secondly, I think so you had asked one question about for K wire. So
yes,
yeah. So what we do, there are two things what we assess is that whether like commonly what we get is the supracondylar fracture. That is one. Second thing we get the fracture around the radius ulna. So sometimes they what they do in a bigger children. So usually in a smaller kids, it with the simple reduction it happens. But usually in a bigger kid, like more than 8 years or a 10-year-old child, so they require the stabilization of the fracture. So during that time, they use a K wire. So talk about the supracondylar fracture, where what we do is that definitely we give a block, and definitely the before giving the block, the surgeon has assessed the if there is any injury to the nerve. So once we come to know that the assessment, usually we basically we work with the pediatric orthopedic surgeons. So our almost 99% we are working with pediatric orthopedic surgeons. So where the assessment about the nerve injury is done in a very methodical way, and so that we explain when we go to the parents and explain about giving the block, so it becomes very simple to explain that this block duration has going to remain for a longer time. In case we think about that they want in a complex like level 3, so there are gradations in the supracondylar fracture, so where like grade 3, or where there is a transverse like fracture which has been in a very transversely cut, so where chances of nerve injury are much more high. So in that situation, practically what we do, we just give a simple plain either lignocaine during the during the surgery. So before giving starting the surgery, so once the induction is done, we give a block with the words just only with the lignocaine, and during that interop, we make sure that the patient remain with the in the, under the block. And then once they do the assessment, sometime in a bigger kit, yeah, definitely once they are fine with the nerve injury, like there is no nerve injury or like child is able to move the hand. So what we have done is that again we make them little under fluorine, and then we inject uh, sensor can where in a concentration of only just a sensory like 0.125% of a sensor can or a bupivacaine or a ropivacaine what we give in these children.
Any
Yeah.
doubts
Yes,
or
well
question from the
taken.
fellows?
I think so. Most of the points were covered. So commonest block what we give, and then you spoke about the you wanted to know about whether we give the forearm blocks. Usually, commonest things almost for last 2 decades, what we encountered around is that either if the fingertip injuries are there, then we definitely the ring blocks which help. It is given usually by the surgeon. Very rarely we would have given just median nerve block or a radial or other. Normally commonest thing what we usually do for any hand surgeries is the infraclavicular block what we give.
Okay. So just sharing what we have done in a couple of cases.
Mm-hmm.
Usually I stick to axillary if it's anything below the humerus and the elbow. I'm talking about single shots. So whatever calculating the upper limit, we a small dose of xyloADR and
Mm-hmm.
0.2 ropivacaine
Okay.
instead of. So the xyloADR action stays for the motor action stays for a good 1.5 to 2 hours, and then the analgesic action. So they don't stay numb and paralyzed for a very long time. So we've done a couple of cases because it acts fast. We've so doing some cases with uh, taking them under sedation with a Hudson mask. But of course, airway has to be, you have to be prepared for management of the airway. Giving the block, and the requirement is very, very less. So you can, in fact, do without giving GA also. But I'm not saying it's like it should be kept as a ready-made option. These are these tips and tricks so that if auxiliary is given with xylocaine, adrenaline, whatever, we don't exceed the dose, then a forearm block can be given, or a mid-humeral block for the surgery of the digits or the hand or anything mid forearm and ahead.
Yeah.
And that nothing more than 0.2 ropivacaine.
Like what happened with us is that a lot of times like we do a lot of the cases what she mentioned about the radial ulnar synostosis or where we have to do
Major
osteotomies.
cases. Yes.
Yeah. So in
Yes.
those cases, we definitely don't prefer to give axillary block. Then we try to give
Definitely. Major cases, you
infraclavicular
should
block.
give it a little higher.
Yeah, so that is what the clinical practice is that say a lot of congenital anomalies we have. So either they do ulnar osteotomy, then they do a nailing, or they will try to do a plating or a radial. So simultaneously, multiple things are happening in the congenital anomaly. So at the two levels, they will do the osteotomy, and then at the distal end they will try to fix with the plate, and the other the proximal end where the fracture is there they will try to do with the nailing. So this permutation combination which is always going on, so then that situation, we try to prefer give a head. I mean, instead of giving axillary, we try to give. Yeah, definitely. We think of giving axillary block in case of like syndactyly cases where definitely you can give. But then again, the tourniquet and everything which comes, so uh, so that we think that better we give infraclavicular. That is what our we do.
Right, but tourniquet usually the baby is under GA, right?
Yeah.
Mm.
So either, yeah, as you said, that dex ketamine combination also can be used. So
Yes.
so that is also there. So usually, what our what we do is that we just give a good midazolam, intranasal midazolam, and then we take under the sevoflurane, and then we have our different techniques of tying the mask, and then put it on a closed circuit, and then just give a good block. So this is one technique what we do, and if you are going to put an LMA, then we give a little bit of the opioid, which we add either fentanyl or remifentanil, whatever which is available, and then give the block. So that is what the main usually what we try to do. If you're putting a LMA, we give a little bit of not a little bit, to be exactly accurate, we give a 2 mics per kg of fentanyl what we add, and then insert then LMA, and then most of like 99% our surgery we try to do it under the regional blocks without any adding anything, because since the children they are not able to cannot remain calm, so that's why either one of the inhalational agent or a propofol, or sometimes what we do is we use a propofol remifentanil combination or a sevoflurane with the air oxygen combination. That is what we do.
Yes. If no doubt, should we conclude?
Yeah.
Sangamitra?
Yes, ma'am. Before concluding, just two things. I would request all the fellows to participate actively next time. Plus, you have to share by tomorrow evening the diagram of individual nerve course from neck to the fingertip as discussed by consultants. And second thing, next class, we are combining the journal club and clubbing it with the class which we have missed on 9th November. That is the RA technique for shoulder and clavicle surgeries. So we are combining these two, and next class will be a combination of both. So please attend, and fellows are requested to participate actively, please. Thank you so much.